Welcome everybody. It is my great pleasure to welcome you to the third webinar on in our series Making Inclusive Insurance Work, which is about telemedicine, insurance and universal health coverage. First, some housekeeping. You will be able to ask questions throughout the webinar. So to do this, please can you use the question box as indicated on the slide. There will be a question and answer session at the end of the presentations. To introduce the webinar organizers, this is a collaboration between the ILO's Impact Insurance Facility and the UN Environment Programme's Finance Initiative. Our vision at the ILO is that insurance realizes its potential for economic and social development. We find that insurance is typically underutilized, not very accessible and not understood very well as a risk management mechanism, especially to the poor and their families. And we aim to change this. Our vision is also shared by UNEP-FI with their focus on sustainable insurance, insurance that aims to contribute to environmental and social and economic sustainability. Today, after I've provided some brief thoughts about the wider context, we will hear from three very different speakers. We have specifically invited them to present on a diverse but complementary range of aspects around the topic with the intention of inspiring you by looking at innovations in MHealth and their use in both public and private health cover settings. Our speakers will provide insights from a number of cases across Africa and Bangladesh. The high-level actuarial impact of such innovations, such as telemedicine, is likely to bring down overall healthcare costs in a system if downstream medical costs are saved through early intervention, prevention, encouragement of health-seeking behavior, and the dissemination of health information. Digitally enabled healthcare also opens up new avenues for efficiency and access. Of utmost importance to us is looking at this in the context of low-income populations, or in insurance speak, the emerging consumer. So to set the scene, I would like to start by asking you, the audience, a couple of questions about universal health coverage, just to check you're awake, because looking at the bigger picture is important, and as I'm sure you all know, health is complex. So I'm going to launch the first poll, and I would like you to answer true or false to the following three questions about universal health coverage. So the first one, these are relatively easy questions, I'm hoping you will get them all right. The first one is, under the definition of UHC, using health services should not expose anyone to financial hardship. So I'm just going to give you a few minutes or a few seconds at least to answer that. Okay. All right, we're on 75% having voted. Okay, I'm going to close the poll. Okay. Right, so I'm delighted to see that most people got that correct. The second question, I shall launch the second poll. So the question here, UHC is organized around providing a specified package of benefits to all members of a society. So if you could cast your vote and say whether you think this is true or false. Just give it a few more seconds. And I'm going to close the poll. So the answer to this is true. That is part of the definition. And the third poll, I shall launch it now. If you can answer true or false. UHC implies coverage for all people for everything. Okay, I'm going to close the poll. So for this answer, we have 14% of the audience thinking that this is true and 86% false. And indeed, the answer is false. By definition, one cannot have a finite and defined benefit package and at the same time cover everything. So what constitutes universal health coverage varies greatly from one country to another. And within a health financing system, it's likely to always be a patchwork of public and private cover and out-of-pocket spend, and a mix of who pays for which types of cover and which organizations provide care. With limited resources, public healthcare will only ever cover a specified package of benefits, which depends on the amount of public financing. So back to the slides, and turning to the UN's 17 Sustainable Development Goals, we see that UHC features in the third goal to ensure healthy lives and promote well-being for all. There are ambitious targets set for 2020 and 2030, which is not too far away. So on this next slide, you can see there are many targets that have been set. And to reach these goals, it's obvious that the most important players are governments, and setting and implementing the right health policies are vital. But when it comes to health, if we are to actually achieve these goals, we're ultimately all responsible for reaching these goals, and we being individuals, employers, and industries at large. And the insurance industry can play a very important role. Aside from looking to governments, people frequently look to the insurance sector for health solutions. And indeed, the insurance's core business is to understand, manage, and carry risk in an accountable and responsible way. Our studies at the ILO on low-income populations show that we frequently find that health insurance of any kind is the most in demand. But an alarming percentage of people in the developing world have little or no access to cover, and where they do, the quality is often poor. Statistics that we have researched in-house is that 56% of the global rural and 22% of the global urban population have no health cover at all. And you can imagine if we just look at the developing world, these statistics are much worse. Health-related debt is also often impoverishing, getting people trapped into situations where there are extremely high rates of interest, and families having to take children out of schools to pay for healthcare. We also find that exorbitant out-of-pocket healthcare costs are a leading cause of bankruptcy, and in some cases we also find that universal health coverage is years away from being realized because it's very complex and governments need support. We also find that insurers want to offer something to the emerging consumer to help with health-induced financial risks, but don't know how to do it in a sustainable way. Other statistics we have uncovered at the ILO is that there's a global health worker deficit of around 10 million people. I won't go into much detail on this next slide, but it's clear that the deficit is pronounced in rural areas. At the ILO, our focus is on financial inclusion, and this includes access to insurance cover, be that from governments or the insurance industry. Access to these services is key to development. Uninsured risk has devastating consequences on families and their future generations, and also constrains businesses. So the questions are, what can the insurance industry do to contribute towards reaching the SDGs on health and well-being? Of key importance is not to undermine government efforts to reach UHC, but to act in a complementary manner. Another question is, what can governments do to increase access and quality but keep costs down, especially in resource-poor settings? So MHealth, and in particular telemedicine, promises to be part of the solution. So with that introduction, I would like to introduce the first of our three expert speakers, Dr. Peter Benjamin, who will start by telling us a bit about what MHealth is. Peter will speak again later in the webinar on telemedicine in the context of government health schemes and how this can support achieving UHC. And I just want to tell you a bit about Dr. Peter Benjamin before he jumps in with his presentation. Dr. Benjamin is Director of Health Enabled, which is based in South Africa. It's a non-profit organization which builds integrated digital health to improve health outcomes at scale in countries of the global south. He has 25 years of experience in the use of information and communications technology for social change and development, and has worked for numerous organizations including PopTel in the UK, SA National Civic Organization, MHealth Alliance and others. He is originally from the UK and moved to South Africa in '94 and has his first degree in physics, a master's in information technology, and his PhD examined universal access to ICTs in South Africa. He's currently studying for a master's in public health. So with that, Peter, over to you.
Lovely. Thank you very much, Lisa. I'm very glad to be speaking to you all today. We're talking about how to get improved health and provide universal health coverage in support of the Sustainable Development Goals. Well, first, health is more than healthcare. A lot of the other sustainable goals around housing, water, safety have a very major impact on health. But given that we're talking about healthcare, what we're trying to do is to provide access to a package of quality care to everyone on the planet that is affordable, exactly like those polls suggested. And using the fact that the great majority of people, literally, in the world now have a cell phone, can't we use that as a way in to providing exactly what was said, to access a package of quality care for all people that is affordable? MHealth, the use of these tools, is one of the few ways that can happen fairly quickly and at mass scale. And there's 100 ways to say, to give these statistics of the use of mobile phones, but I quite like this graph. This is showing, if you like, the history of telephony. It starts in the late 19th century, where Alexander Graham Bell had the first telephone conversation that he invented. Along the bottom is that little green thing, which is the number of fixed telephone lines in the world. And if you see, it peaks at just over a billion about a decade ago, in the mid-2000s. The blue line is the world's population, which is now of the order of 7.5 billion. The extraordinary thing is that in the last 2 decades, mobile phones, cell phones, have exploded and changed the way, basically, the planet communicates. And there are now more than one cell phone per person in the world. Of course, that is not evenly distributed. People in Europe, North America, Japan have 2 or 3 cell phones each in many cases. But a majority of people literally in Africa have a cell phone. There's some extraordinary statistics. There are more cell phones in Africa than there are toilets in Africa. And I'm currently in rural areas of Uganda on a MHealth project, and the figures are 85% of people in the country have access to a phone. Next slide, please, Lisa. So what is MHealth? MHealth is the practice of medicine and public health supported by mobile devices. It's an extraordinarily recent term. Just about a decade and a half ago, it was first typed down, those 7 letters. So it's extremely new. It takes that long to get a drug from invention out into the market. And in that period of time, MHealth is being used throughout the world. The first of the major conferences starting the field was in 2008, literally less than a decade ago. And the technology that can be used in these mobile devices, while we normally think of cell phones, mobile phones, and perhaps tablets, there are many other things. monitoring devices that are mobile on patients, the telemedicine providing care. Think of from a clinic, a video link to a health specialist in a hospital who can help diagnose skin cancers or other things like that, dermatology. A lot of systems for data collection, which is used on many forms of technology. In North America, if you talk about MHealth, what most people think of is applications, little programs you can download to your smartphone. And someone counted, there's about 120,000 of these, they're called MHealth apps on iStore and Google Play. So there's a huge, and what someone told me the most effective of these fitness apps is actually Pokemon Go. It's got more people walking around than all the fancy athletic systems. Social media also is used for MHealth. Gamification, it's called, trying to encourage people to do healthy behaviors through peer support, winning prizes, earning points, things like that. And there are also, you may know, lots of health and fitness wearables, Fitbit and lots of other things. So not just on your cell phone, you can wear it around your wrist, some are even woven into clothes. And in many ways, what these systems are is the interface into the wider digital health, electronic health, ICT for health. Don't think of it just what is the power of that individual device. Think instead, this is the way in, this is the entry point to all the other information systems that can support patient records, linking to physicians, linking to health insurance, to lab results, within the health system, efficiencies, management systems, and the like. Next slide, please. So there are many different areas that MHealth can cover, and that was one of the earlier divisions. But next slide. The one that is most used in the sector comes from the leading research expert called Alan Labrie, based at Johns Hopkins University, working with the World Health Organization. And because I don't really want this to be an eye test for you, could we move to the next slide, please? Which is the listing of those 12 areas.
So, Peter, we'll have to pick up on that slide later on in your presentation. So hold those thoughts. So that is an introduction to MHealth. I asked Peter to introduce MHealth. I truncated his presentation by one slide, but we'll get there towards the end, so hold that thought. So next up, we have Jody Delichte, who will be telling us about some of the latest MHealth and InsurTech developments and behavioral economics in the context of health insurance. So to introduce Jody, she has over 20 years experience leading global marketing programs in the IT and telecom space. Prior to joining Inclusivity Solutions as Chief Marketing Officer, she was Marketing Director for the GSMA's Mobile for Development division, where she worked with mobile operators around the world on sustainable life-enhancing services for the underserved. Jody is currently pursuing a PhD where she is studying the impact of programs for bottom-of-the-pyramid entrepreneurs. So, Jody, I would like to now hand over to you.
Great, thanks, Lisa. And if you can just change the slide, I'll just take a moment to quickly introduce Inclusivity Solutions. For those who are not familiar with us, we design, build, operate, and innovate digital insurance solutions. We work in partnership with mobile operators, insurers, and other partners. And our team have worked across more than 40 emerging markets in Africa, Asia, and Latin America. And so we've seen a lot of development and growth in this space, but I think there's still a lot more work to be done, and we can evolve further. And that involves looking at things maybe through some different lenses. So you can change the slide, Lisa. Now, I was on a webinar last week, and I spoke a bit about some of the concepts of behavioral economics. It's an area I like to talk a lot about and look at a lot, especially with respect to how it applies to microinsurance. And one of the things that I talk about is time inconsistencies. Now, this is basically related to the fact that people tend to place higher priority on short-term benefits over longer-term rewards. So there may be people on this call who maybe at some point have had a goal to lose weight or get more fit. Maybe that resonates with some people. But next thing you know, you find yourself at your desk, you're working late, maybe you're a little bit stressed out, and there's a sugary snack close by. And so you grab for that sugary snack. And at that moment, you're more focused on the short-term benefit that that sugary snack brings you than the long-term benefit of being fit. So I talk a lot about this present versus future focused in the context of emerging consumers and insurance in particular, because on the one hand you have insurance, which is a future focused product, but on the other hand you have emerging consumers who are extremely present focused. Often they're just looking at how to get by every day. So there's quite a mismatch, and this holistic offerings that bundle information services, teledoctor services, and other more immediate benefits with insurance are very useful because they can help bring a future-focused product into the present tense. And offerings like Telenor Tonic, which Andrew is going to speak about shortly, are good examples of this. So I'm glad he's on the call to tell you about Telenor Tonic because I often use it as an example in this context. But it's not just about bringing something psychologically from a future focus into a present focus. There's a real present need for these kinds of services. So last year I was talking to an organization called A Consultants in Kenya who conducted a study in 8 slums in Kenya to understand the health-seeking behaviors of women of childbearing age. So the study included about 470 respondents. And one of the things that they learned was that if the women are unwell, they won't go to the clinic unless it's absolutely required, even if it's relatively close by, because they don't want to lose income. They can't afford to lose that day of income, which is understandable. But of course, if something is serious and it gets worse, it could lead to more time off work later, or higher costs later, or even worse, it could lead to loss of life. So this is where I see that things like telemedicine and teledoctor service can help address a real challenge and a real need. Can you change the slide, please, Lisa? So this is where I get really excited about services like Babel in Rwanda. Babel's a digital health clinic that launched in Rwanda about 4 or 5 months ago, and they work with over 30 doctors and more than 20 nurses. And to register, people dial a short code using their national ID. Now, if someone has a health issue and they need a consultation, all they have to do is dial *811# to request an appointment, and then they receive an SMS to confirm that they have an appointment and what time that appointment is at. And then a nurse phones them at the allocated time to do an initial consultation. And then if further consultation is required with a doctor, then another appointment is made and the doctor will then phone at that allocated time. The consultations over the phone cost about 40% of the cost of a consultation at a government clinic and about 20% of the cost of a consultation at a private clinic. And typically these are paid for via mobile money. Now, if the person requires a prescription, the doctor can enter the details into the system and the person will receive an SMS with a code that they can then take to one of 200 partner pharmacies across the country who then enter the code and bring up and fulfill the prescription. Now, the other interesting component to Babel is that people with smartphones can use video on their smartphones and do video consultations if they need to show a doctor a specific condition, if there's something they need to show. And Babel has also set up booths with tablets and 4G internet in some pharmacies and at other locations for people who don't have smartphones but have the need to do something visually. So within 4 months, they had more than 320,000 customers register, and they've done over 80,000 consultations. So it's exactly services like this that I get really excited about, because these types of services can be linked to other products like insurance to provide more holistic offerings that include both present and future benefits and more fully address the needs of emerging consumers. Can you change the slide, please? Another example of innovation that I tend to like to talk a lot about is Discovery Vitality, which I'm more familiar with being in South Africa, but it does exist in other countries as well. And now the Vitality program is based on 3 core components. So that includes health information and education, tools to help reduce barriers to getting healthy. So tools in this context include things like discounted gym memberships, cash back on healthy food, smoking cessation courses, things like that. And then it includes different incentives to motivate people. So that's things like discounts on flights or spas, hotels, movies, and things like that. Now, Peter mentioned the concept of gamification just a moment ago, and Discovery Vitality includes an element of gamification. So you'll get points for various activities like doing a health assessment or going to the gym or participating in a health event like a running race or something like that. And as you move up through these bronze, silver, and gold levels, you'll receive bigger discounts on incentives. So you get a bigger discount on a flight or a bigger discount on a hotel. So what they're doing is basically incorporating the human driver to gain something or to achieve something into the program. Now, some people are motivated by gain, and others are actually more motivated by the fear of loss. So some studies have shown that we're actually more likely to change our behavior to avoid loss than to make a gain. And Discovery Vitality takes this into account as well. So I know some people here in South Africa who know exactly what vitality status they're at. They know if they're bronze, they're silver, they're gold. They know exactly how many points they need to get to the next level, and that's what motivates them. Personally, I'm not motivated by that. What motivated me to go back to the gym last year after a bit of a brief absence, if I have to be honest, were messages that I got from Vitality saying that if I didn't meet my required number of gym visits, my discount was going to decrease from 75% to 50%, my gym discount. So I was determined to not let that happen, and I quite quickly, I think the next week, got back into the gym. So it can be different for different people, and we also need to look at where some of these studies have been done. There are more of these studies being done now in emerging market contexts, but a lot of them were still from more developed markets. So we really need to test what works in a given market. Last year we did some message and imagery testing for a microinsurance product in Uganda, and we found that people resonated with what I would call slightly fear-based messages about what lost if they weren't covered by insurance. But we found that they needed to see this message paired with a positive image that actually showed a person that was okay and being taken care of, and they wanted to see that person smiling and feeling secure. So we found we had to actually mix these two drivers because that's what resonated with the audience. You can change the slide, Lisa. Now there's a guy named Yukai Chu who developed a framework that analyzes, or it's based on the analysis of human motivations and behavior, and it's called the Octalysis Framework. And it's a framework I'm just starting to dive a lot deeper into to understand in more depth and look at how it could be used, or how some of these concepts could be used to help drive positive behavior change for emerging consumers. But briefly, the framework includes 8 core drives that influence human behavior, and I've talked about a couple of these already that Discovery Vitality uses. So at the top left there you can see accomplishment, that's the earning points and the moving up different levels. And on the bottom you can see avoidance, which is what I talked about around kind of the fear of loss. So he sort of splits these up into four different types of quadrants, and the ones on the far left, so the accomplishment, the ownership, and the scarcity, are very much left brain. They're associated with logic and calculations and ownership, and they tend to be more extrinsic motivators. So they're things that drive people to want to obtain something tangible or intangible. Whereas the 3 on the far right, the empowerment and the social influence and the unpredictability, are much more intrinsic motivators, and they're more related to creativity and self-expression and social aspects. And then the other 2 ways that he distinguishes between them are the 3 at the top versus the 3 at the bottom. So the 3 at the top, accomplishment, meaning, and empowerment, are positive motivators. So they're things that make people feel good. They make people feel powerful or satisfied or fulfilled. So this is where that different status levels of the Vitality program fit in, where people feel good. They feel like they're achieving something. They're moving from bronze to silver level. And the 3 at the bottom are more negative motivators. So people are doing something because they don't necessarily know what's going to happen next, or because of fear. So that, again, that sort of that fear of loss, or that, unpredictability. If you think about gambling or lotteries, they can drive people to continue to want to play. The problem with these ones at the bottom is that sometimes they can become a bit addictive or obsessive. So that may make you think that actually it's better to just focus on the positive drivers as opposed to the negative ones. But what UCI says is that the positive ones are not always better depending on what you want to achieve, because it's actually those ones at the bottom that tend to create more a sense of urgency than the ones at the top. For me and my gym discount, it was that fear of loss that made me do something immediately. It wasn't the thought of gaining more points and moving to the next level. So those ones at the bottom can help move people forward and create that sense of urgency. So it depends on what you're trying to achieve, and it also perhaps depends on what stage of change someone is at. And Lisa, if you change the slide, I'll briefly just talk about the different stages of behavior change that that we need to keep in mind when we are trying to move people to more healthy behaviors. Research has shown that action-oriented programs don't work for all the stages of behavior change, and different interventions are required at different stages. And this is where the Discovery Vitality model will work well, because they use information and education to build awareness and understanding, which are very important in the early stages of behavior change, or almost the pre-behavior change stages, you might want to call them. But then they provide these tools like the gym discounts and these incentives to help move people into action and ideally help them to maintain healthy behaviors. So I'm currently doing some work to look at the Discovery Vitality type of model and look at how it can work in a more emerging consumer context. And I do think there's a lot of opportunities for this, but we need to better understand what tools are most useful for emerging consumers, as well as what types of incentives will actually motivate them to take behavior change and maintain that behavior change. And one of the big challenges in the emerging consumer context, of course, is verifiable data to actually measure behavior change. So in South Africa, I scan my gym card, or I connect my wearable, Peter talked about wearables, to the Vitality app, or I scan my grocery card to show that I bought healthy food. And these types of data aren't as readily available in emerging consumer contexts. So we need to think creatively and see what might work. But I do think there's a lot of great opportunity to take these learnings into account and offer emerging consumers more holistic offerings that include different information and services like telemedicine and insurance to inform, mobilize, and protect emerging consumers.
Great.
I will leave it there for now.
Thank you so much. That was very interesting, and I hope it's inspired some thinking in our audience as to maybe how to design things slightly differently going forward. So now I'm going to be handing over to Andrew, who is going to give us a case study. Just move his slides along. So he will be presenting to us on his experience with Tonic in Bangladesh and the experience of telemedicine as part of a microinsurance offering. To give you a bit of background about Andrew, Andrew is currently Chief Operations and Performance Officer for Telenor Health. It's a mobile health startup with almost 3 million customers in Bangladesh, whose offering brings together micro health insurance, health provider networks, telemedicine, and digital health content. Andrew leads their service delivery insurance offerings, digital channels, and their partnerships with hospitals, labs, and pharmacies. Prior to Telenor, Andrew worked for the International Healthcare and Insurance Group, Bupa, as Mass Market Development Director and Sustainable Business and Partnerships Director. There he helped to develop and launch innovative microinsurance offerings for the emerging markets, corporate partnering with mobile operators, digital health programs for behavior change. Andrew is passionate about human-centered research and design and creating new products and businesses that transform access to healthcare and well-being. So Andrew, over to you.
Thanks, Lisa, and good morning, evening, afternoon to all of you guys online as well. I'm going to spend 10 minutes giving a whirlwind tour of what Tonic and Telenor Health are up to in Bangladesh, looking at our offerings, so what are the services that we're bringing to consumers in Bangladesh, our impact to date and some insights, and then a little snapshot on kind of where next. So Lisa, on to the next slide. But I think where I'll start is really the kind of the context. And I think as Peter and Jody were sharing, whether it's Bangladesh or Southeast Asia, we can see there are going to be 800 million new mobile internet users for the first time by 2020. Every single year, there are tens of millions of people driven into poverty by the cost of ill health, and there's a massive need for scalable, commercial, kind of universal healthcare models. So how do we get quality healthcare, affordable healthcare into people's hands, into their lives, where it's never kind of gone before? So Telenor Health, who are we? The next slide, Lisa. We are a startup of Telenor Group, the kind of Norwegian mobile operator active in 10 to 12 markets in Asia. The vision of Telenor Health is health for all. So how do we democratize access and quality to good health? And we want to help every single one of our members get cheaper healthcare, better healthcare when they kind of need it. So the next slide, Lisa. And I guess what are we combining as a business? We're bringing together really three things. So we're a healthcare business. We have roughly 35 doctors in-house and an amazing chief medical officer. We also bring that human-centered design approach to everything we do. So how do we make every one of our services kind of simple to use, quick to use, fulfill the emotional needs that people have as well as the rational needs, and actually bring technology to bear. So as Peter was saying, the amount of kind of data that is out there that we can bring together to serve people personalized healthcare, that's what we need to combine. So on to the next slide, Lisa. And our ambition really, by combining telemedicine, insurance, discounts, digital health tips and content, is to become the digital front door, initially for millions of people in Bangladesh, but then into other countries across Southeast Asia and beyond, and be that digital front door between them and their kind of health providers and health needs. So what are the services that we're providing? Lisa, next, so the kind of needs that we're meeting. So there are three core consumer needs that we're really focused on. So one is around people not being able to find reliable information about staying healthy and about healthcare. So Dr. Google, very unreliable. The network of family and friends that people would often touch in Bangladesh or India or beyond to ask health questions, not that reliable. And how do we help people then find the right care they need? So whether it's a doctor, a pharmacist, a specialist, people don't know where to look. So how can we help them navigate that system and find the right doctor or the right expert for them at the time they need it? And the last piece of the puzzle, which is a focus for a lot of us on this call, is healthcare is too expensive. So how do we make healthcare more affordable and help people kind of pay for it at the moment of payment? So the next slide covers our products, which we're calling Tonic in Bangladesh. We launched it in mid-June 2016, so we're roughly 7 months in. And our launch product brings together four great features. So one is Tonic Cash. It's micro health insurance, hospital cash that pays 1,000 Bangladeshi taka when you're in hospital for 3 nights or more. And the entire end-to-end insurance is delivered over the mobile, claims, payments, enrollment. We've also got Tonic discounts, so 250 hospitals, labs, pharmacies, lifestyle partners around the country who are part of our network, and when our member goes there, they are given a discount off the service with 1 SMS being sent. The other piece we've got, which is the core spine of the service, is what we call Tonic Doctor. So in-house, about 35, 40 doctors now, available 24/7, fully qualified, and they're not just providing telemedicine as a standalone service. We've now got a full kind of electronic health record, tracking previous health events. We can do prescriptions for medicines via SMS and follow up health tips based on the consultation that someone just had. And the final piece of the picture is Tonic Wellbeing, which is health tips via Facebook, web, Android app and SMS, including health heroes, so using famous doctors, using cricket stars, using yoga instructor stars, using infographics, using comic strips, but all backed by a robust medical base. So all of that together, 6 months in, we've got some great evidence of early impact. The next slide, Lisa. So as Lisa kind of said, we're at 2.85 million members. The last month we've been growing at 15 to 20,000 members a day, so big scale up in Bangladesh. And what you can see in the first 6 to 7 months, we're already the largest health insurance program in the country based on the first 6 months. We've made our first almost 2,000 payouts of the insurance, and the time from first contact to payment is 5 days. So we know that getting the money into consumers' hands is a big builder of trust. On discounts, we've already served about 20,000 people with discounts across those hospitals and pharmacies. With our doctor service, we've conducted almost 160,000 full medical consultations through our in-house doctors, the telemedicine service. And through our well-being tips and hints, we've got a daily reach of about 1.5 million people, primarily through kind of Facebook and our other channels. And we see almost every day about 9 or 10% of those pieces of health content being shared with family and friends, so forming that kind of community of health. And a big piece for informing the future of our offerings is data. So from all of those touch points, the health and well-being content, the medical consultations, the insurance, we've now got 200 million data points across the healthcare journey for our members. So but big opportunity to look at where kind of next. So Lisa, next slide. And I guess a deep dive for 1 minute into clinical quality, because just making something more affordable or accessible we know is not good enough. So as part of our telemedicine service, we've adopted really world-class symptom and disease management protocols. We've got rigorous training, continuous improvement of all of the doctors, and we've adopted a custom electronic health record system. So every one of those consultations captured, tracked, so that the next time someone calls, we can do follow-on advice. And really importantly, no major clinical complaints or incidents in 7 months. So a deep dive into affordability and access. The next slide, Lisa. And what you can see here is some of the early kind of data points on our microinsurance and our discount network. So roughly 1 million Bangladeshi taka kind of dispersed in microinsurance claims. In our discounts, we've had a couple of customers who have saved $1,000 on open heart surgery for their relatives. And for context, that's kind of annual earnings in Bangladesh. So big kind of discounts for people kind of there. And there's a customer testimony on the slide about the kind of father's open heart surgery and the difference that we made. So it really is helping to make key surgical procedures much more accessible. So on to kind of where next. Next slide, Lisa. And I guess there are two pieces that are our focus for the coming 8 to 10 weeks. One is a launch in the next couple of weeks of a range of new features and new bundles of services, including chatting with doctors via multiple channels, so not just on the phone, but via other modalities, bringing together digital health checks with real-world health checks in partner labs and partner hospitals to really help someone get peace of mind or know where they need to go and see a specialist. We're going to introduce appointment booking kind of nationwide, so with hundreds of doctors around the country, not just our own doctors and our own facilities, and we're going to have much more valuable microinsurance that covers 10, 20, 30% of the cost of care for key procedures and bundles up key packages of care to make it much more affordable. The second piece in terms of where next, which is my second last slide, the next one, Lisa, is really measuring our impact, and we're looking to measure that in kind of 2 ways. So in universal healthcare terms, how do we cover ever more of the out-of-pocket expenditure that our members are facing, so that whether it's the discounts or the insurance or the provider network, we're helping people with more of their out-of-pocket spend. And how are we spreading our offerings to a greater proportion of the nation so that we truly go to the bottom of the pyramid, not just the upper kind of bottom of the pyramid where we're currently focused. And then the final piece of impact assessment that we intend to commence very soon is looking at the combined impact on access, on utilization of care, including just basic patient satisfaction. And we know from the evidence that Johns Hopkins, that Peter mentioned, have gathered, that where you provide great experience through your telemedicine service, people are much more likely to do the follow-up that you recommend, to see a specialist or get a scan. So that will be our focus, really focus on kind of quality, utilization, and driving down the cost of care. And to end, kind of 10 minutes was my limit to end the final slide. None of this is possible in Bangladesh or anywhere without some really hardworking, kind of dedicated people. And I think that the team that we've pulled together in Bangladesh that you can see on this slide, I've got some amazing talent on kind of designing around people's needs, around bringing to market innovative technology solutions. And I think this shows that the power of consumer-led businesses to really deliver health for all and universal healthcare in a different way. So there you go, Tonic.
And Andrew, thank you very much. That was great. I'm very excited about what you're doing, and it's wonderful that you're able to share all of this with us. So at this point, I'd like to hand over back to Dr. Peter Benjamin and ask the audience to shift your brains back into the sort of thinking about telemedicine and the public health context. So Peter, over to you to pick up where we left off.
Great.
You may need to just quickly recap on the slide.
Thank you very much, Lisa. And interesting, Jody and Andrew, your work in Tonic is truly stunning. Where I was previously is in Alan Labrie's division of 12 different areas that MHealth and Telemedicine can cover. I won't go through all of them. You can see Jody talk about the first one, client education towards behavior change. There are various other ones you can see there. But I'd just like to highlight the last one that in many ways Andrew touched on, the financial transactions and incentives. For many people in the world, their cell phone is the only way to make an electronic payment. They don't have bank accounts, they don't have credit cards. So both to make payments to health workers, like community health workers, wives and the like, and to receive payment on health insurance, that in many ways is talked about as that actually is the killer app. That is the huge thing that cell phones, mobile phones provide. If you like, if you know the phrase, the bottom of the pyramid, mobile phones is now the way to monetize the bottom of the pyramid, to get transactions in and away from. On to the next slide, please. There are many, many different MHealth and related projects around the world. This is a map produced by the World Health Organization. There's something called the Global eHealth Observatory that just published a new report at the end of last year talking about all the different countries around the world, and as you say, actually a great majority. And many of the countries who are not there, it's just that they didn't report properly to the WHO. Next slide, please. So, while there are literally thousands of these projects around the world, sadly we're finding that many of them are fairly small, supported by donors, and when that comes to an end, there is little follow-up. Next slide, please. A very famous example of this actually comes from the country that I'm currently sitting in Uganda, where there was a little study of many of the different MHealth projects, and that produced this map that looks like measles and is referred to as pilotitis. There are too many pilots, but we can't actually fly. There are lots of little projects that don't connect together, and so the whole move of MHealth over the last few years is trying to move away from small pilots to integrated systems that can scale and be on large scale sustainable. Next slide, please. And the community, the several dozen companies, NGOs, universities, researchers, donors involved in this field, basically came together and came up with what are referred to as the 9 principles of digital development. These are the things you should be doing if you're trying to use new technologies like mobile elsewhere in areas like health in the global south, in the developing world. And it's not that you are guaranteed to succeed if you do these, around. If you do these, you're almost guaranteed to fail. And you can Google the principles of digital development and find them very quickly. If you're thinking of doing something like this, they are the best place to start. And it is sometimes phrased as fail fast, learn quickly, do it again. As you heard, there is a lot of changes and adaptation in the field. On the next slide, thank you. These are the large-scale MHealth Systems throughout the world, and this came from a USAID study, the MHealth Compendium of last year. I'm afraid it came out before Tonic had come to the millions. It definitely would be there near the top. Thank you on that slide. There is Airtel Insurance. If we can go back to that list. Airtel Insurance, thank you, Lisa, is a micro-insurance project in 7 African countries that is impressive, but not as scaled as you've just been hearing about with Tonic. Aponjon is a maternal health messaging in Bangladesh, part of the Mobile Action Mobile Alliance for Maternal Action. So these are the 10 large-scale MHealth systems that in the world last year. CStock is supply chain management, being able to track drugs and other supplies in facilities through mobile phones, SMSs, and other tools saying when they're running out of drugs or other things. ICCM stands for Integrated Community Case Management, and that's a mobile tool for health workers to actually provide healthcare services, not just as many health workers do health promotion, but actually doing some diagnosis and giving out some medicines in Malawi. Kilkari is a large-scale maternal health messaging system in India. MHero in West Africa provides SMS to supporting the care provided by health workers. MSOS in Kenya is disease surveillance. So when there are outbreaks of different health problems, mobile is the fastest way for the national government to know about this and respond. Rapid SMS in Rwanda is SMSs out to support maternal and child health in what are called the 1,000 days. That's from conception when the fetus starts inside the woman, delivery till the baby's 2nd birthday. And there's a lot of medical science now saying that is the most crucial time to determining in how long that person will live. U-Report in Uganda is a huge, extensive adolescent messaging, counseling, and polling system to basically support a whole population around safe sex and staying HIV-free. And next slide, please. And Mum Connect in South Africa is the one I know best. Next slide. I'm working in the South African task team that's running Mum Connect. It was launched just over 2 years ago by our Minister of Health, Dr. Aaron Motsoaledi. There he is. Next slide. And it is a SMS system sent out to exactly over 1 million women, about 1.1 million women now, providing SMSs to support them through their pregnancy and after delivery till the baby's 1st birthday. And that is now being done in 97% of health facilities in the country, the great majority. Next slide, please. So one thing I'd like to come to, MHealth can do a lot, but it is not itself health intervention. No one got better by receiving an SMS. That's not how it works. What it can do is provide access to the triggers of behavior change, exactly as Jody said, provide that information to persuade you. or it can provide reduce the delays and make much more accessible links to the health interventions that are known to work. This slide is taken from the Lancet, the medical journal, and saying those are the real health interventions that we know keep infants and children alive. These are the things that can be done between birth and age 5 that keep babies and children alive. Evidence-based, this is what medical is. Next slide. So clearly, what we're trying to do is move from interventions of known efficacy, things we know work, to get effective coverage. Next slide. That is the job of universal health coverage throughout the world. And next slide. However, there are various things that block this. There are failure to follow guidelines. You don't get quality care when you turn up at the facility. There can be drug or supply stockouts. There can be poor demand for services. People don't come to the health workers or the facilities. And you can think what MHealth does in this context is jump over those hurdles. If you like, it is a health systems catalyst. It isn't the intervention itself, but it is the way that these universal health systems that we know work are made accessible, affordable, in quality services that people can access, which is just another way of saying universal health coverage. Next slide. So going back to what Lisa started us with, we are talking about universal health coverage as the primary goal under Sustainable Development Goal 3 around good health. But I'd just like to re-emphasize that health is actually to do with many other things through there. Poverty affects health. Good water affects health. Access to nutrition affects health. So in many ways, health care is only one smaller part of what actually affects how long people live and how healthy they are, mortality and morbidity. Next slide. And this is the head of the World Health Organization, Dr. Margaret Chan, expressing exactly this, that universal health coverage is the most powerful concept that public health has to offer. That is the job over the next 13 years or so, to provide good quality health care throughout the world. Next slide, please. And the key point I'm trying to say is that MHealth and these sorts of distance health interventions can be of use at all different stages of this universal health coverage. This slide is again taken from Alan Labrie, Johns Hopkins, and Garrett Mell of the World Health Organization, showing at the different levels from at the bottom, availability of services, to, so that people know about and come, the supply, so you get good quality health services and care, the equipment, the knowledgeable health professionals, the demand, which means people know their health care and when they should come in to get it, the quality and the cost. At all of these levels, the MHealth can be used to improve universal health coverage in all the different dimensions you're seeing here. Next slide. The organization I work with, Health Enabled, doesn't provide a particular system or app or database. We work with large-scale health implementers like departments of health to get three things together to get these things, we believe, to work sustainable, impactful scale. The first is national policy. The second is the sustainable programs, all those things we said in the principles of digital development. And thirdly, effective use. So it actually impacts and has a positive benefit to whether it's the patient or the health system. Next slide, please. So, just to come towards the end. Over the next 5–10 years, in countries of the global south, can we move to making the fact that the great majority of people have a cell phone become the primary point of contact to the health system? Currently, accessing the facilities, accessing nurses and doctors, as you heard before, is very, very difficult. In economic terms, it's an extremely high barrier to entry. So in all these different ways, like providing health information for all, WikiHealth 100 by 100 is a project to get the 100 most important health issues in a little Wikipedia, simple to understand article, translated into 100 languages that 90% of people in the world speak, and through cell phones accessible to people throughout the world. Supporting the personal change, like Jody was talking about, stopping smoking, eating better exercise, being able to call in to a doctor, the triage, exactly as you've heard the excellent model from Tonic, then being able to tie into emergency response. So a distress call can lead to some response. There isn't access to professional ambulance services. In several countries, there are now community ambulances. The community agrees one person with a car is on call who can take, for example, the mother who's hemorrhaging to the clinic, and that can be organized through mobile to get a much faster response services. There are apps like WellDoc for diabetes that are now proven randomized controlled trials to greatly improve adherence to be able to follow the regimen to keep yourself healthy with a particular disease, to the level that WellDoc is now formally prescribed. The doctor writes it out on the slip, prescribes someone to take it. If they adhere, meaning they use the app, they put in their blood glucose levels, then it actually ties into their health insurance. It reduces their health insurance if they use this app properly. And so that's these systems being fully embedded into the health system. And there's a whole area called preemptive health, which is like the next stage of health promotion and disease prevention, allowing people to know how it will impact their own health through their health record, their family history. Like if they don't cut down on the beer, they're more likely to get diabetes or liver disease in 5 years' time. Next slide, please. So just there's a lot of information out there. This is a set of the different reports that have come out. And next slide. Rather than just bombarding you with 100 documents, the best place to find more information is mhealthevidence.org, run by Johns Hopkins University, that collects most of the literature, studies, what works, what doesn't. And then on the other side of the screen, the mregistry.org, which is the repository of many of these projects around the world. Next slide. So, sorry. So coming towards the end, health is more than healthcare. And mHealth can extend access to health services outside the clinic. Almost all the other sorts of e-health and digital health are about improving health system efficiencies, linking the clinic to the hospital, to the lab results, to the patient record system, to the insurance or payer. mHealth allows these services to extend out to where people live, because literally most people now have a mobile phone in their pocket. And you've heard great examples of that from Andrew and Jody. So mHealth, I don't need to say it again, they're all in the services on evidence. Next one. What we have learned so far is that these systems hugely help with data collection. Any form of collecting data, patient records, surveys, if you've got can get over the cost hurdle of getting the cell phones and systems, it is hugely cheaper, faster, better management for the health system if you do it electronically. There's some example of supply chain and lab results management system, because just like in any big business, electronic systems can help, whether you're a corporate selling motor cars or supermarkets, these electronic systems help. So it's not a surprise that they help in a large-scale industry, business, public sector like health. Supporting health workers with what's called decision support, so giving them tools so they're not on their own trying to diagnose something, particularly low-level community health workers. there's good evidence of that. And EMR means electronic medical records, where particularly at facility level, you have much better records, so you don't have the piles of paper in a huge pile in one corner. We've actually got systems that can improve quality of care. On behavior change, some things really work, and Jody was talking about that. Many things don't. Just spitting out SMSs saying, eat 5 vegetables a day, floss your teeth, use a condom, see the doctor, take the pill, doesn't change much. You have to be much more sophisticated in the way that Jody was saying, understanding the motivations of people. And roughly, where people want to make a change, like stopping smoking, saying, these systems can help. Where it's trying to persuade people of something they really don't want to do, it's much, much harder. So yes, it can be a great tool. It's one of the few new innovations that genuinely can support universal health coverage, national health insurance, as it is in various countries. It is a lot cheaper doing these systems than building another 1,000 health facilities, which is another way of accessing healthcare. And this way it can scale so quickly because the rollout of cell phones has largely happened. It's certainly not for everyone. Everyone has a cell phone. The great majority of people in almost every country now have access to some form of cell phone, though the Jody of the GSMA can give the latest statistics. So what we're really saying is, can we make mobile health the new normal? It's not a little MHealth project, isn't that nice? But it is now the way to do large-scale public health in the developing world. Health system strengthening, linking people to care, behavior change, preemptive health. This is the way you do it. You use the tools that are there. Next slide. So my favorite quote in this area is, these tools don't get socially interesting until they're technologically boring. Clay Shirky, an internet theorist, said that a few years ago. It is not the absolutely amazing things you can do with the latest iPhone that will change the world. Because the people who can afford an iPhone probably already have internet to get information, probably have enough money to get good quality health already, or large-scale health insurance. Can we use the fact that in South Africa, 90% of youth and adults, throughout the world, about 60% of people have access to a mobile phone? Can we use that as the primary way to promote health and link to healthcare? If we can do that, we can change the health, and therefore we can change the way people live throughout the world. With that, thank you very much to Lisa.
Thank you so much, Peter. I think there is a wealth of information on your slides. Thank you so much for sharing your insights. Just to let people who are listening know, we are actually recording this webinar, and the slides will be available after the session. If you would like to take a deeper dive into any of the links or papers or anything that any of the speakers have mentioned. So just quickly, before we move on to the Q&A session, I think it's worth just taking a step back and having a few concluding thoughts from the ILO. As I said in the beginning, health is very complex, and there are lots of different aspects of looking at healthcare and healthcare financing. But I think it's important to stress that in order to reach the scale from the insurance side, the old models of doing health insurance don't necessarily work. Our research shows that market-based, fully comprehensive micro-insurance is not viable and cannot reach scale. But this doesn't mean that insurers should close shop and give up on supporting their health SDG. Simple health products such as hospital cash plans and telemedicine can be shown to be profitable and sustainable, but for more comprehensive cover, government subsidy is needed. Innovation around simple, cost-effective health and complementary innovations are where the insurance industry should look when designing new products. And very briefly, this is one of our flagship charts that we show people when we talk about healthcare. The facility has observed that the following evolution within healthcare financing, which is worth a quick mention. The horizontal axis on this chart represents the maturity of a healthcare ecosystem. So a combination of time, political commitment, management capacity, infrastructure, resources, and so on. On the vertical axis are dominant and less dominant providers of health coverage. And we observe that before government UHC reform kicks in, communities start to organize health cover themselves through CBHIs and HMIs. These, however, are often inadequate substitutes for government coverage, but in some cases they do form the foundation for health social protection. As time goes on, the insurance industry in many countries finds more success in focusing on providing subsidized or complementary products such as hospital cash and telemedicine, and like the products we've just spoken, and also partnering with governments on specific pieces of the insurance value chain. So there's lots of scope, I think, for insurers to be innovative, and especially in the new world of MHealth. So at this point, I will turn to the questions. We have a lot of questions and unfortunately not a huge amount of time to answer all of them. So what we will do is we will go through a couple of the questions, but all the questions that are unanswered we will gather and put together in a document, answer them and circulate them to everybody who is on this webinar. So going up to the first question, I will try and answer these in order and direct them to the right person. So we have about 4 minutes. We might go a little bit over. But first question is from Susie Cheston. She says, health insurance is most in demand compared to what? Other kinds of insurance or other forms of health financing. So this was on a slide that I mentioned right at the beginning, and when I said most in demand, I was talking about different types of health insurance. So insurance. So if you do a market research study and you ask people, would you like life insurance, health insurance, general insurance, generally what happens is health gets voted as the most in demand. So the second question that I will ask is, okay, from Shilpi Nanda, MHealth, slide 2 from Dr. Benjamin, could be everything from wearables to apps to IoT devices. In your experience, is there a particular initiative or device which has greatest impact on public health from an engagement perspective and also from an outcome perspective? Peter, do you have any thoughts?
Thank you. Thank you for that. In the developing world, I think the answer is fairly clear. You're right, and as that slide says, it can be so many different things, but the obvious point is go from what people have. And currently, the majority of phones in the developing world are basic, or what are called feature phones. And so we're talking about SMS and, you know, USSD voice if you can afford it. But the interesting thing is that the sector of phones that is exploding is smartphones. While the majority of phones in Africa, for example, are not smartphones, smartphones are only about 1/3 of them. What is striking is that about 80% of all new phones bought are smartphones. So within a couple of years, there are different studies that say by 2019 or by 2020, the great majority of even the people in impoverished areas of Africa, Asia, Latin America, a very large number, majority, would have access to smartphones. And as you know, the sad truth in life, it is a lot more expensive to be poor. Similarly, using the things for basic cell phones, SMS, USD, voice, is much more expensive at large scale than using data to link into smartphones. So my answer to your question, Shulpananda, is currently the most impactful of the tools that people have, which is largely the basic and feature phones. But absolutely in our work, in planning for the next couple of years, smartphones and in particular Android phones rather than iPhones or Nokia Windows or the like. So the single largest impact and where we should build things on, both for health workers, nurses, community health workers, doctors, and also within a couple of years for the general population, is Android smartphones and the whole number of things we can do around that, including diagnostics. You can get pulse and a range of different diagnostics that absolutely make your cell phone a health tool. Thank you, Lisa.
Okay, great. So I'm going to take one more question. I'm so sorry, I have seen we have got many questions flooding in, but like I say, we will answer your questions and circulate the answers in a document. But just one last question. So from Yasuhiko Kamakura, how do you maintain the quality of doctors' services in telemedicine? Great question. How do you overcome doctors' competencies? Do they work as a team in telemedicine? To which extent can doctors provide best medical services? So Andrew, you mentioned that there was some kind of monitoring and quality control about the services provided by your doctors on your panel. Would you like to jump in and just say a little bit about that before we end?
Yeah, definitely, Lisa. So I guess we've got two approaches we've taken. So one is what I shared already around, clear protocols, clear training, continuous improvement and retraining, and that's all essential. There's like a whole raft of basics that we've done to keep the doctor's knowledge up to date and them fully trained. But I guess the second thing we've done that I think is just as important is how do you keep them motivated? Because a lot of doctors didn't go into medicine to sit in a contact center and answer the phone. So how do you keep them motivated? And some of the things that we've done is had competitions weekly and monthly about obviously how much clinical data can we capture, had competitions around the kind of consumer net promoter score, so how much of consumers loved the experience of having their medical consultations, and again use the data that's coming through to like incentivize the doctors and motivate them. So it's not just kind of traditional medical training, it's how do you get them connected to the impact they're having on patients on an hourly or a daily basis in terms of clinical data, NPS, etc. And just one other thought, because we didn't answer it, the other question from a minute ago about insurance and demand for insurance. And I say this as an ex-insurance guy for like six years at Bupa. I think the truth is that in emerging markets, most people, most of the time, don't want insurance of any kind, whether it's health or life. They think of insurance as a category as a rip-off. They think of a lot of the providers in the market as being untrustworthy, not paying out, etc. So I think that's why we've constructed Tonic as a bundled service where there is insurance to pay for catastrophic events, and people are interested in helping to pay for catastrophic health events, but labeling it insurance and having insurance as a standalone, I think that'll limit the size of the market to quite a small pool, whereas bundled services where health financing is part of healthcare have a lot more potential, I believe.
Absolutely, Andrew, I would agree with you. Despite my comment about health insurance being the most in demand, I think when people are given a closed set of options, they pick that. But you're absolutely right. I think it's not the most appealing thing to say, would you like to buy insurance? And bundling is very important. And perhaps this is where the insurance industry can think about providing health services rather than health insurance through a bundled product. So thank you again for everybody's questions. We've got some really fantastic questions that have come through, so I encourage you to read the document when we circulate the answers. Just before we say goodbye, I would like to just tell you a little bit about our upcoming webinars. So as I mentioned, this is a series of 7 webinars. Our next webinar will be on the 16th of March on SMEs and value chains. And also, please, when we say goodbye to you, you will have a survey that will pop out. Please take a moment to fill this out because we use this to improve what we do, and also we use the feedback that you give us. So the last thing before we say goodbye is that there is a second webinar on health. The date will be is to be advised, but if anybody on the call has ideas about what you would like us to present on, we can take that into consideration as we formulate our next health webinar. So with that, thank you so much to all of our speakers, and thank you very much to all of you who dialed in, and we look forward to seeing you back here on the 16th of March. Thank you.
Thank you very much, Lisa, and to all the participants.
Great. Thanks all. Goodbye.